Welcome, everyone. This is session 7.3 of the What Works Global Summit, Communicating Evidence and Knowledge Translation. We're glad to have you all here and look forward to a really great hour coming up with some fantastic presentations. I know there may be some people still joining us, but we do have a pretty packed agenda here, so we want to kind of get going with our first session, and we're going to be joined here by Tamara Lotfi.
Thank you, Kathleen. Thanks, everyone. Hi, everyone. Just double checking that you can see my slides. All right, great. My name is Tamara Lotfi. I'm a project lead for the COVID-19 RecMap, which I'll refer to as RecMap as we go on. If you are on your computer or your tablet, feel free to check out covid19.recmap.org. If you have any questions later on, feel free to drop me an email or use Twitter to contact me, and I'd be happy to answer your questions. I'm based at McMaster University. This project is based at McMaster University in Cochrane, Canada, McMaster Grade Center, funded by CIHR, and in collaboration with a long list of partners that I will talk about in a few. To start, what is the COVID-19 RecMap? It is an online, easy to navigate, living, freely accessible electronic platform on which we present COVID-19 recommendations. The way we do that is we have a systematic search that's been ongoing since June 2020 for COVID-19 guidelines. We capture those, then we screen them in duplicate, and we appraise them using the Agree-To tool, which is a quality appraisal tool for guidelines. The appraisal takes place using 2 raters to provide 1 score. And what we do on the RecMap is present these recommendations in a tabular format. So as you see here on the top left corner of the slide, every cell is an intersection between the population, so the rows on the left, the intent, infection control, vaccination, screening, diagnosis, and so on. And the intersection cell represents the number of COVID-19 recommendations that we have captured. We looked for any COVID-19 recommendation, any COVID-19 guideline, regardless of the topic, regardless of the population it covers. And we presented all the information, including the recommendation text, the certainty of the evidence and recommendation strength when available for an actionable statement, for in particular for a formal recommendation, and the scores of the Agree-To tool. To note, the Agree-To tool has 6 domains. Each domain is scored from 1 to 7 for its different items, and we provide 1 score per domain. On the RecMap, we chose 3 only that reflect most credibility, but all the other domain scores are available per request. And so what we also do is, as part of the RecMap, it's also a gateway to contextualization. So we make all the recommendations available for contextualization or development, so adoption, adaptation, or de novo synthesis through our RecMap. Just to say that we have a large team that is, sorry about that, that is distributed largely. It's the efforts of all the team, all the groups coming together that has actually allowed us to succeed in the past 2.5 years. So we have more than 30 organizations and groups together all over the globe. Right now, up until today, actually, we have 177 researchers who have contributed to making this RecMap available, living, and as up-to-date as possible. And reporting a number from Google Analytics for now, over 26K users from 169 countries. So quickly in numbers, as of October 3rd, so just last week, we've captured 5,695 citations on COVID-19 guidelines, out of which 466 guidelines have been extracted and presented on our RecMap, which amounts for 6,063 recommendations. What I want to point out here is, even though it is a RecMap, a map of recommendations, we've also had the opportunity to do a lot of research work. You can find all the publications we've done on the RecMap if you click on the toolbar on the right side. And these research publications include looking at whether recommendations from the same organizations or different organizations are saying the same thing for a particular PICO question. population intervention comparison and outcome, or whether there's any divergence there. We were also able to lead on a big project, the plain language recommendations, which my colleague Rana will talk more about the trial that we're conducting on that. And I'm just putting out here the achievements that we were able to do for the coming year, as we are leading on our third year of the funding. We have 10 groups that will be focused on knowledge mobilization, in particular to make sure the information in the RecMap is reaching the right audience, whether through the RecMap itself or through plain language recommendations. I would love to share more information with you about how we do the plain language recommendations. Please feel free to drop me an email or ask any questions. And other than that, we also have a list of webinars and presentations all available online for free. And I think I made it right on time. Thank you.
You sure did. That was fantastic. So now we have some time. After each of the 5-minute presentations, we have about 3 minutes to take questions. So I don't know if any of you all would like to ask any questions now. I actually do have a question, Tamara. So this is a map of COVID recommendations, and it's been really clear during the pandemic that there's a lot of false information about COVID. So how did your team sort out bad recommendations versus good ones?
Thank you for that question, Kathleen. So our role was not to make the decision on what is good or bad or what to present. Our role was to commit to presenting as many of the COVID-19 recommendations out there and provide a quality appraisal. So to leave the decision of what recommendation to choose or not to choose in practice or for a patient to the knowledge users themselves, based on the quality that we provide and based on all the other information that we provide. And I must just make sure it's clear that we extract the information as they are presented in the guideline. We only make our own judgments in 2 fields in the RecMap. One, the quality appraisal itself, it's completely independent and we do it within our team. And 2, it's part of the research output that came up. We've classified the type of actionable statements that come out. So not every recommendation that came out in COVID-19 guidelines is actually a formal recommendation. We've seen a lot of informal recommendation. We've seen a lot of good practice statements that were not labeled as good practice statements. So we try through the RecMap to actually label these and provide our judgments there. And if any of the attendees here are guideline developers who have captured their guidelines there, please feel free to reach out if you would like to inquire about why your guideline statements were classified as such.
Great. So I'm not seeing any other questions, so I think we can just move on to our next presenter, because there may be questions that come up, and if we have time at the end before the hour ends, we'll turn back to questions. And so we're going to be joined by Rana Charide from McMaster University.
Thank you, Kathleen. Just going to share my screen. Okay. So, hi everyone. My name is Rana. I'm at the HEI department at McMaster University. And today I will be informing you about our 3 randomized control trials testing the plain language recommendation format, which is part of the work we're doing on the eCovid RecMap, which my colleague Tamara just presented. So the aim of these three double-blinded superiority RCTs is to enhance and improve the way that we are presenting the guideline recommendations to the general public and to consumers. Our 3 target populations are youth, parents, and adults. Our intervention is the plain language recommendation format, and quickly defining the plain language recommendation format is an easy-to-read summary of formal and good practice statement recommendations that are published by guideline organizations. And the comparison or the control is the standard language version of the recommendation, which is the original recommendation that is published by, as it is by its original format that's published by the guideline organizations. And our outcomes are understanding, usability, satisfaction, intended behavior, and preference. So our project overviews, our project consists of 3 different phases. The first phase was the pre-trial pilot work, which involves stakeholders and representatives from the 3 target groups. They helped us mainly to pick out the topic that we're going to test in our trials, and they helped us optimize the way the plain language recommendation format is presented. They also had us pilot test the survey to make sure all the questions are clear and the survey is easy to read. And they also gave us feedback on our recruitment flyers. The second part of the project is conducting the 3 double-blinded superiority RCTs. So our target sample size is 240 participants per trial. Our primary outcome is understanding, and we define this as the correct comprehension of the key findings from the recommendation. And our secondary outcomes were usability, satisfaction with the format, intended behavior, which means if the participants are willing to follow the recommendation in its current presented format, and the preference to either formats, the plain language recommendation or the standard language version. And the third and the last part of the project is qualitative interviews. So at the end of the trial, our participants were invited to participate in a one-on-one semi-structured interviews to give them an opportunity to give us more feedback about the plain language recommendations, about the format of the plain language recommendation, their preference, and to enable us to contextualize our results. This is briefly our trial flow. So the participants are first invited to take part in the study. Then they are screened for eligibility criteria, and then they give consent. After that, they are stratified by region. The main aim for stratifying by region is to make sure that the participants from all regions get equal opportunity to be allocated to either the intervention or the control. Then the participants are randomized to one recommendation topic. We use 2 different topics of recommendations to make sure that the participants are not biased by the topic. And then after they are randomized to a topic, they are randomized to either the intervention or the control. At this stage, they have to answer questions relating to understanding, accessibility and usability, satisfaction, and intended behavior. After they've answered this set of questions, we disclose the other format. They can view both the PLR and the SLV, compare them, and then answer questions regarding preference. Then we conclude the survey with questions relating to demographic background and health literacy, and we invite them to take part in the qualitative interview. So to wrap up, so far we have concluded our recruitment for both the youth and the parents trials, and we're still recruiting for the adult trials. Our preliminary results suggest that there's an enhanced understanding among the group who was allocated to the PLR format as compared to those who were allocated to the standard language format. And so really the impact and our findings suggest that the PLR format is more friendly and easier to use and understand the main guideline information. And for future research, we recommend that there's more focus on how to increase the uptake and usage of these plain language recommendations among the public. I hope I made it on time, and this is my email in case you would like to reach out for more questions or details about the trial.
Perfect. Thank you so much, Rana. So I'm curious, were there any systematic differences in preferences? You mentioned that it was youth-friendly, but were there other elements that some other demographic groups preferred?
So our results show that among both the groups that viewed the PLR format and the SLV format, the skewness was more towards the PLR format. There was no other or particular demographic factor that influenced the preference. The feedback was that it was easier to read. They were able to capture the main information in a friendly format.
Mm-hmm. And how long were the reviews, the PLR pieces? How many words, more or less?
How many words?
Whatever. Were they like just little abstracts, or were they
No, it's not an abstract. They were divided into different sections. So the first section would indicate the question of the recommendation, and then the intended population in bullet points, and then a small section that would say the importance of this recommendation, provide some additional information. So it's like a one-pager, and at the end it will give a brief information about the benefit and harms of following the recommendation. And at the end there's an information of what if the reader wants to get more information, where they should go to.
Thanks, that's really helpful. I have a center I direct has a plain language summary tool, and AIR, where I work, does cognitive testing fact sheets. So it's very kind of analogous, but your research is much more rigorous. So congratulations. Okay, so I don't see any questions yet from others. So I think we can move on to Emmy De Buck from the Belgian Red Cross.
Okay, thank you. Let me share my screen. So my name is Emmy De Buck. I'm head of the Center for Evidence-Based Practice at the Belgian Red Cross. And in my talk, I'll give you some insight in how we developed evidence-based guidance materials for lay people on how they can help other people experiencing mental health problems. So it is clear that family and friends are in many cases the best placed people to see early problems or early signs of mental health problems and to give initial help, which we also call first aid, and to refer people to additional help when needed. And that's why we developed an evidence-based guideline and corresponding guidance materials specifically for the Flemish context in Belgium. And this was a project in collaboration with Zorgnet Curo, which is an umbrella organization covering several care organizations and health centers in Belgium. And it was a project at the request of the Flemish government. We focused on communicative interventions because these are really low threshold first aid actions that are feasible to be performed by lay people. And examples are talking, comforting, and so on. And we covered 12 different mental health topics from addiction to traumatic events and several other topics. So first step in our project was to collect the best available evidence. And we did this by collecting evidence from several scientific databases. Then we assessed the certainty of evidence by using GRADE. We screened more than 30,000 references and finally included 90 studies for which the evidence was in most cases of very low certainty. And we developed 12 different evidence summaries for the 12 mental health topics. And then in the next step, of course, we wanted to translate all this knowledge into practical materials. And our colleagues from the first aid department drafted a manual. And this first draft of the manual was then discussed with an expert panel, which is actually the third dimension of our evidence-based practice methodology. And this expert panel was composed of several professional experts, including psychiatrists and psychologists, but also patient representatives were included, so people with lived experience, which was very important for this topic. And we organized 5 expert meetings and collected their input, which was very valuable and very necessary also, because for a lot of topics, not a lot of evidence was identified, or the evidence was of only a low or very low certainty. So this resulted in 33 recommendations for across the 12 mental health topics. And for a lot of, or for some of these recommendations, we found quite some evidence. But for a lot of other recommendations, there was no evidence available, and it was really important that together with the panel, we could formulate additional good practice points. So the input of the panel was particularly in this project very valuable. And then in the next step, we developed several materials to translate all this information and to disseminate. So first of all, we had the manual or the handbook, which can be bought in the bookshop. But then with our marketing department, we also developed several promotion materials. And then during the COVID crisis, this mobile application was also developed. So the COVID crisis actually accelerated the development of additional materials to reach as many as possible, to reach as many lay people as possible. We also organized trainings. So therefore, Red Cross volunteers are being trained and then give these trainings in 4 sessions of 3 hours spread over 4 weeks. We also organized some digital initiations. This is only a teaser, 1.5 hour introduction to the topic. And then we also organized trainings at the request of companies and so on. So just to wrap up, we found some evidence on first aid communication interventions, but not for every recommendation. And in many cases, it was of low to very low certainty. So because of that, the contribution of our multidisciplinary panel was really essential to be able to write relevant recommendations and to develop relevant training materials. And we then developed different low threshold materials to be able to reach a lot of lay people. And we work together with a lot of organizations. You can also find my contact details here. And if you have any questions, I'll be happy to answer them.
Thanks so much, Emmy. So I know in your title that these were developed for lay people. That's like a lot of people. So
Yes.
Were there any particular kind of segments of that audience that you had in mind? Or that is ending up, using this?
Actually, the focus of first aid is really that anyone can help another person. So we really wanted to specifically target just anyone for any initial support. So it's really about low threshold support that people can provide to other people. So it's really a broad group. But it was not so easy to set our criteria for the project because we excluded any professional help or professional interventions. We just focused on what lay people can do just by talking to other people. So it's more on communication between people. Yeah. I think you are on mute, Kathleen.
Yeah. There's the live Q&A there at the bottom. So I don't want to, hog all the questions. Feel free, audience or even presenters, to put in some questions there if you have them. I was wondering too, though, while people are mulling that over, there are these 12 topics, Emmy. And so that was could you describe again how those topics were derived?
Yes, we discussed with a working group at the beginning of the project and also with all the care organizations that were involved in the project. And it was just based on prevalences and what is most important topics for our context. So that is how we decided to include these. Yeah.
Yeah, it's interesting because I think a lot of people think of the Red Cross as primarily disaster recovery, and I didn't realize that as many of these, like eating disorder or things, would come up. So
yeah,
we have a very broad scope.
Yeah, it's also a new activity for our organization, and yeah, in other Red Cross national societies, the focus is indeed more on traumatic event and disaster. But we were contacted by our government. They knew that we were developing evidence-based guidelines also for physical first aid, and that's how we rolled into this project, yes.
Understood. Yeah, well, it looks really valuable. I'm going to check the Q&A one more time, and I think we are ready then to move on to Claire Allen, who's joining us from Evidence Aid.
Thanks, Kathleen. My name is Claire Allen. I work for Evidence Aid as the operations manager. I'm just sharing my screen now. Hopefully you can see that. Evidence Aid is a registered charity in the UK. Its vision is to save lives and livelihoods in disasters by providing decision makers with the best available evidence and by supporting and advocating for its use. I'm presenting to you today about our resilient health systems evidence collection on behalf of my colleagues who are listed in this slide. Evidence Aid provides freely available structured evidence summaries of systematic reviews around topics related to the humanitarian sector. We hope to improve access to reliable information to support well-informed decisions regarding disasters, health emergencies, and crisis situations. Our summaries are generally curated in what we call collections, which are topic specific and have categories you can search, as well as being able to search across all collections and with keywords. Our collections cover diverse areas such as windstorms, earthquakes, health of refugees, COVID, managing mental injuries in disasters, to name but a few. Our most recent collection, which I'm going to talk about shortly, is Resilient Health Systems. Our structured summaries, which I spoke about earlier, have changed over time to ensure dynamic living documents responding to decision makers' needs and have evolved considerably within the last 3 years because of the work that we've done around COVID and latterly the resilient health systems. Our most recent change was to include sections on implications and equity. In 2021, we partnered with the Pan American Health Organization to collect, curate, and summarize systematic reviews of relevance to resilient health systems, with particular relevance for low and middle income countries, focusing on the Americas. Searches were run by topic areas, and evidence summaries structured to include publication data, topic, methodology, findings, implications, and equity considerations. We categorized summaries within the resilient health systems and cross-referenced them to other relevant collections, ensuring the summaries could be downloaded by the user or the entire collection embedded on any organization's website. Summaries are drafted, edited, and finalized before being sent for translation into French, Spanish, and Portuguese to cover the target countries. In 2021, the topic areas included were telehealth, migrants, post-event recovery and surge, rural capacities, protection of healthcare workers, and mental health. And my next slide will show you the results of those searches, as well as our updated searches in 2022. So phase one, as I said, took place in 2021, where we had 5,652 potential systematic reviews for inclusion, with 1,725 reviews screened by both PAHO and Evidence Aid. Phase two started in May 2022, and we identified an additional 1,939 potential systematic reviews, with 566 screened by both PAHO and Evidence Aid. You can see from this slide that there was one updated but expanded search from a simple search for migrants to include refugees and displaced populations. In 2022, we included non-communicable diseases, hospital preparedness for services off-grid, and the public response to chemical, biological, and radiological emergencies. In 2022, we also worked with PAHO to produce an enhanced gap map of the new topic reviews. We had done this in 2021, but we produced a simple list of gaps rather than having a more extensive mapping process. We currently have more than 200 summaries of systematic reviews relevant to resilient health systems, with another 20 scheduled for publication in the next 2 months. We're discussing phase 3 with PAHO, expanding the topics and priorities, and adding further analysis of the systematic reviews as they're summarised from the learning, using the learning from phase 1 and phase 2. Thank you for listening. Please don't hesitate to contact me should you have additional questions or should your organisation be interested in partnering with us to curate a collection around your topic of interest. My email's on the screen. I'd be really happy to hear from you. Thank you.
Wonderful. Thank you so much, Claire. I noticed that you mentioned climate change, so I did want to just, this isn't a question as much as a comment. Campbell is planning a What Works Global Summit in June in Berlin, specifically focused on climate change. So you may want to keep your eye on that to the degree that some of this relates to it.
We'll definitely do that, Kathleen. Thank you.
For sure. So I'm toggling back and forth in between the live Q&A here as well as presenter chat. And, all of y'all, you don't need to put anything in the chat. You can, if you do have any questions for each other, because I think we will have time for a discussion at the end, a more synthetic discussion. So, feel free to engage in that. I don't see any questions in the live Q&A. What? Here comes someone. I don't think there are any participants. Okay. We do have 1, 2, 3, 4, 5, 6. There are people here. Maybe it's not a view, but if you click on attendees, you can see who's in the room. I don't know if you recognize any of those names, but. Okay. Well, why don't we go ahead and move on to our next and final formal presentation from Ving Fai Chan of Queen's University Belfast.
Thank you. I'll try to share my screen now. Can you see my presentation?
Yes, we can.
Okay, thank you. My name is Dr. Ving Fai Chan. I'm a lecturer at Queen's University Belfast, and I am presenting on behalf of my research team. I am going to speak about the Zanzibar Arts for Children's Eyesight, or the Zanzibar AIDS program, how we have co-created the materials, what we have achieved, and also what we have learned along the way. So this project is implemented in Zanzibar, which faces a lot of infrastructural challenges. For example, the roads are in very bad condition, and also public transport is not very reliable. So going for health services is a big challenge. With about 1.8 million population, there are about 20,000 children who need eye care services, but the services coverage is as low as 5%. And there are plenty of social and cultural barriers. So the preference for services lies in the traditional medicine. And in terms of eye health education, there is either very little investment, or if there is investment, there are signs of unacceptability. Where you can see in the image here where children are trying to remove the posters from the school. And that's how the Zanzibar AIDS program came about, where the conventional eye health education did not work. We tried to do something a little bit more creative. So for phase 1, we have 3 components. We started off with a 2.5-day co-creation workshop in Zanzibar, trying to understand what are the local barriers, needs, and also attitudes towards eye health. And then followed by understanding from the local stakeholders what exactly do they think is the most effective art form, and also the key messages to be included in the Zanzibar AIDS material. And one of the outputs is also to develop the theory of change map. Then this is followed by a 1-month music competition and also judging of the music entries. So some of the findings from our workshop. Number one, if you look at the barriers to service uptake, they are mainly social and cultural in nature. In terms of preferred art forms, the one that ranked number one is music and songs. And in terms of key messages, there are 6 of them, but I'll only share with you the top 3. Number one is that taking care of eye health is your own responsibilities. And if you have an eye health problems, you have to seek services from the hospital. And good eye health is critical for a child's well-being. This is the theory of change map developed for the program. And in just briefly, what it says is that if the environment is enabling, if we can improve the eye health knowledge of the people, we will be able to improve service uptake. With that, children's vision will be corrected in a timely fashion and the well-being will be improved. So with the competition ended, we have 6 music entries and these are the 3 winners. And these musical pieces cover a few genres. The first one is traditional Arabic music called Tarab. The second one is a little bit modern with some rhythm and blues element. And the third one is the marriage between the traditional and modern music, which is a little bit contemporary popular music. So what I'm going to do is share a snippet with you, the music pieces. So this is just a short snippet. So if you want to listen more, you can go onto our Zanzibar's website. Lastly, just share some few lessons learned along the way. We have some successes where we are able to affirm the assumptions on eye health needs and barriers. And with 34 stakeholders participated in the workshop, we were able to achieve our preset outcomes. And we were also able to work according to the principle where we created by the local for the locals. But along the way, we also had plenty of challenges because we did this work during the very strict travel restrictions during COVID-19 pandemic. So we had to be very creative how we carry out phase 1. And also with 34 very enthusiastic stakeholders, it was quite difficult to reach consensus between researchers and implementers. Sorry. So thank you very much. If you want to know more about the project, you can go on the Zanzibar's website or you can email me as well. Thank you very much.
Of course. Well, thank you, Ving. So I'm kind of curious, did you, it's under the term eye health and you're not specifically talking about vision. So were there broader issues with eye health aside from, just not being able to see?
Yes, so we try to move away from the word vision because we try to be more inclusive. That's why we use the word eye health. In terms of eye health, other than how good someone can see, there are also other asymptomatic diseases. For example, if you look at a child, even if they have cataract, you can't see it, you can't see it easily. So you have to do certain examination to do that. The other one, which is quite prevalent among children, is conjunctivitis, red eye. So that's why we use the word eye health to cover a spectrum of eye conditions.
Okay. And of course, there's a lot of motivation when someone has conjunctivitis because it's uncomfortable, whereas people don't necessarily know they're myopic.
Definitely. Especially with children. There are plenty of stigma as well, where children who wear glasses will be teased by their friends. And girls who wear glasses tend to be not able to get married. And that's what people really think. So there's plenty of stigma around wearing glasses in the community.
Mm-hmm. Yeah, there is a saying, it's Dorothy Parker was a kind of like a writer in the 1920s in the United States, and her thing was, guys don't make passes at girls who wear glasses. So that's not a prejudice unique to that country, but I don't think it's necessarily true anymore. But obviously, it is in some places. So I'm curious, I'm going to throw this back on presenters here. There are kind of some commonalities among what you're doing, and I just wonder if any of you have been noticing about things that, you know, practices you might adopt or ways that you think you might collaborate or could collaborate. For example, we had 2 presentations on COVID, and I didn't even know if you all were aware of each other's efforts. I would imagine so. Or... So that was the first 2 presenters, in case anybody's joining, right? So
yeah, thanks, Kathleen. We're actually under the same project. So the PLR trial that Rana presented was we were able to do that because we had led on all the work that we've done with the RecMap and tested the PLR. So the PLR trial came as a next building block. But it's great to hear from the other presenters, actually, especially on the concept of capturing, presenting, optimizing how we deliver the information, finding information that's duplicate in regards to the same research question, and all that. This is all important, whether it's at evidence synthesis level or it's at recommendations level, right? And it's the same thing, you know, we share methods, we share a systematic way, the rigorous methodology for both, whether it's, again, mapping or delivering the output as a publication. So there's, I think, a lot of lessons alive that I've learned. And in particular, for example, with COVID-19, it was not just clinical. It was clinical, it was public health, it was health management, it was global health, it was so many different components. And now the other sectors are only seeing the consequences of COVID. So I think there's definitely room for collaboration, whether it's cross-sectoral or across the different levels of evidence.
Yeah, and I'm pretty sure that Epicenter at University College London has also done work on a living evidence COVID map that might be of interest to you if you're not aware of it. I think Claire.
Yeah, I was just going to say that Evidence Aid has also got a COVID collection, which I know I briefly mentioned. I was charging through my slides because I couldn't see anything to say that I was nearly finished. But yeah, we've got a COVID evidence collection, which has over 600 plain language summaries inside of systematic reviews. And those are applicable not just to COVID directly, but also the indirect effects of COVID. And we've also worked with COVID End based at McMaster. So just to say that, yeah, I think there's collaboration going on, even though it's not necessarily completely direct between one and another of us. We've also worked with Emmy and the Red Cross for many, many years, looking at systematic reviews that go into many of our different collections.
Correct.
And it was interesting to see Dr. Chan using art. Are any of your other organizations using art for communication as in various forms, and in addition to text?
We previously, in 2014, 2015, did an arts-based project using comic booklets in rural Tanzania. It was a very successful program called Vision Champion, Children as Agents of Change. It wrapped up in 2016, and what we found is that we were able to improve people's eye health knowledge. And at baseline, at the eye health clinics, we find that the people who are going to the clinics are very few. So when we finish our projects, there's about 400% increase in the patient load to the eye health clinic. So that was quite successful. And then in 2018, when we wanted to start this Zanzibar AIDS program, that's what actually the Zanzibar Ministry of Health wanted to do, is to replicate what we have done in rural Tanzania in Zanzibar. And we were very adamant that we can't just replicate. We need to be needs and context specific, and that is how we came up with this music and songs from the local stakeholders that they felt this is the best way to go about in Zanzibar. I do believe there are other arts-based intervention as well. For example, they have the work in the Gambia for maternal and child health, where they use local ladies who are good in dancing and poetry. So I think they did fantastic as well. And during the Ebola outbreak in Liberia, they also use certain drama going around villages to spread the knowledge around preventing Ebola. So I think there are a lot of learnings from different art-based programs around the world.
I mean, it's definitely one way to involve people from the community.
Definitely, especially art space, especially in Africa, music is just part of people's life, and that is how you get people involved in interventions like this.
I have a vested interest in all of what you're doing. I run a Center on Knowledge Translation for Disability and Rehabilitation Research, and we just had a recompete. And I did put in to have an arts showcase, and our reviewers really wanted me to figure out a way to evaluate it. So it's interesting what you're doing. Another thing that has happened at the American Institutes for Research, I'm seeing attendees. I think once someone comes in, their name is there, and I don't know if Cindy Kai is still there, but your work reminds me of a project she runs where they took existing information about traumatic brain injury and are adapting it for Native American communities, using a Native American artist to create infographics, which I think was mentioned somewhere. Someone has been involved in that kind of work, and using images as well as text or art. There's a lot of ways you can go with that.
And I think in Latin America, there is also a program using telenovela, which is loved by the people from that region. So as I said, there are plenty of arts-based intervention out there, and people are very creative around how to conduct those interventions.
So we do have a question here from Cindy Kai, who is the principal investigator of that traumatic brain injury project I just mentioned. Do you have the link to learn more about the art-based projects you just mentioned? I think this is directed to you, Dr. Chan.
Yes, it's in the SANCA's website. Will the
I think maybe if you put it in the presenter chat, and then I can drop it into the answer questions.
Sure, I will put it in the chat box. Okay, give me the. Okay, I'll put it in the presenter chat. You can share it with the attendee. So by the way, we have just finished phase 1. Now is the phase 2, where we are going to pilot test our product or materials before going for the randomized control trial, which is phase 3.
Okay, I just got that over to Cindy. We're getting an applause. It's a communication strategy that somehow, if there's silence, that people we'll fill it. So I'm just giving you all the opportunity to formulate your own thoughts. And you can all just listen to my dog here whining in the background. I don't know if you can hear that. I know one of you was asking if the sessions will be available after the event for us to share. I am not aware of that, and I think not. And I think what I'll probably do for that question, unless someone who's in the control room can answer it first right now, is find out and then email all of you like I've been doing part of the panel. If we don't get a response pretty soon. Okay, I'm just checking the live Q&A one more time. Cindy is saying, I think the recording will be available for 70 hours. And Annaleanne V said, thank you very much. It was very interesting. Yeah, so the sessions are recording. We're just not sure where they will be posted. So I'll try to stay on top of that as your moderator and let you know. Okay, I have to toggle back and forth between presenter chat and live Q&A, so I'm just checking these one more time. And I think for some of, wait. Okay. I think for some of you, it's pretty late already. I know it's many hours behind all of you. So we can go ahead and let you all, in some cases, go to bed. But thank you so much for a great session. Bye.
Thank you.
Thank you. Bye.
Bye.
Thanks, everybody. Bye.